Good afternoon, everybody. I hope everybody can hear me in the room okay. Yes, is that audible at the back? Great, good. Well, welcome to the RSE and to this event focused on transforming Scottish healthcare, the role of data and technology, which is being organised by the Royal Society of Edinburgh in collaboration with the Foundation for Science and Technology. I'm Sarah Curtis. I'll be chairing this event in my role as a Fellow of the RSE. I'm also an Honorary Professor at the University of Edinburgh, and my own academic research involves analysis of large data sets relevant to health and healthcare in collaboration with the Centre for Research on Environment, Society and Health at the Universities of Edinburgh and Glasgow. And so I'm very much looking forward to this discussion. First, can I advise you on one or two housekeeping points, which I think appear here. We're not expecting a fire drill, so if the alarms do go off, can I advise that you should be exiting from this room directly out of this door where you came in. Or if there's any problem getting there, there's also another way out, which is to turn left and left again and exit that way. So follow the signed access on the right wall. Going out into Rose Street Lane is the alternative. The assembly point is outside the dome on George Street, so people would assemble outside. Please don't stop to pick up belongings and so on in the rest of the building if we do have to leave quickly. Those who are in the room today, could I just point out that there's a bit of a trip hazard just here as you're leaving or coming onto the seats. So please don't forget that as you're coming and going. And I'd also like to say that we are using Slido to aid in our Q&A session after the speakers have presented. To log on to Slido, you will need to access the address here. I think you may find that if you just dial into www.sly.do.com, that will get you in. You can present a question at any time. As you dial in, you will need the event number 3531376, and you can ask questions as the presentations are progressing. And people who are in the room can do it that way if you wish, but we will also be using microphones if you prefer to do it that way, and some of the staff will be patrolling with a microphone, and you can put your hand up nice and high, please, so that I can see you, and do it that way. Looking at the focus of the event, we're all aware that the healthcare system in Scotland, as in all parts of the UK, is facing major challenges. There's a long-term problem with no easy or single solution. The underlying question, though, at this event is to what extent can a greater use of data and technology in Scottish healthcare contribute to addressing these problems? We accept, of course, that this is only part of a wider solution that will include additional funding and staff. We've got a number of related questions that we hope to explore in the discussion. What are the new healthcare technologies that are being developed, and how can they be deployed? Are there specific benefits to more remote, rural and island communities from using more of these technologies? What are the ethical, regulatory and practical issues involved with use of these technologies? And what opportunities are there for Scottish universities and industry in developing these technologies? We've got a great panel of speakers here with us today. We're going to hear from Jonathan Cameron, Deputy Director of Digital Health and Healthcare, Scottish Government, from Patricia Connolly, Deputy Associate Principal of Biomedical Engineering at the University of Strathclyde, Professor Oliver Lemon, co-academic lead at the National Robotorium, and also from Jonathan. So we have 4 speakers today. And my next job, without more ado, is to invite our first speaker, Jonathan Cameron, to the rostrum. Thank you. As Jonathan's getting set up, just briefly introduce him a little more. Jonathan is the head of the Digital Health and Healthcare in Scottish Government and has overall responsibility for the digital health and care strategy and major programmes of delivery. And he has a range of experience in the application of IT and e-health in various sectors, especially relating to healthcare. So thank you very much.
Thank you very much, Sarah, and delighted to be here. And on behalf of the Cabinet Secretary for Health and Social Care, really keen to share with you the work that we're doing from Scottish Government. You're relieved to hear there's no slides, no death by PowerPoint. So just a short few introductory words from myself. And as I said, really keen to share what we've been doing and how we're taking forward this challenge. And the way that data and technology is really driving not just health and social care, but our everyday lives. And I was reflecting on the transformation that took place during the COVID pandemic and that overnight interest in technology, the overnight shift to using digital tools, but particularly the interest in data, that overnight explanation of the number of vaccines that have been given. As someone who led the development of the COVID vaccination system, it was incredibly exciting to see how that was changing and transforming the care of patients and how the digital as a whole was seen across the entire public. So I think the other thing I was reflecting on is that technology itself doesn't have to be high tech. Yes, there's some really exciting things happening out there, ChatGPT in the world of AI, but actually what really transforms the lives of citizens is sometimes just the lower tech. It's sometimes just the simple things. It's sometimes just a text message can be all that's needed. And one example that we had that was particularly accelerated during COVID was our NHS Near Me service. So that's our video consulting service. And it became incredibly easy for a wide range of people to use that. But we particularly noticed it in areas like the Highlands and our island communities where travel is far harder, that they were really engaging with the use of technology in this way. I'm really pleased to confirm that we've just announced actually that 60 million patient miles have been saved through the use of NHS Near Me. And for me, it's an example not only of the difference in how that becomes easier for citizens, they're not having to make 3-mile round trips to Raigmore Hospital in Inverness, for example, but it also demonstrates the power that digital and data has for a challenge on climate. And we can't lose sight of the fact that climate change and net zero is probably the next big challenge that we need to address. And from a Scottish Government perspective, I think there's a real opportunity for us all working in digital and data to make a big difference. Can we reduce travel? Can we reduce the use of resources? And so there's some really interesting work that's been done collectively on that. So I also wanted to share today what really underpins a lot of our work is our data strategy. We launched our data strategy earlier this year. And for me, it really focuses on that need to empower people. The drive for citizens and for people to be in greater control of their own health leads to better health outcomes. So how can we open up more data and more services and more information in a safe and secure way that will really make a difference to their lives? We also really want to empower our workforce, and our workforce are the lifeblood of our health and care services. I'll touch a little bit more on what we're doing to support our workforce in a minute. But from a data perspective, putting the data and information and the right tools in the hands of clinicians, nurses, of our staff is what's going to really change and transform health and care for us all. I also really wanted to acknowledge the importance of industry and academia. And actually the third key area for our data strategy is to recognise the importance that sector brings. and the innovation that will come from there, and how, again, how that will really change care for us all. Underpinning the whole strategy, and something we've placed deliberately at the centre of everything, is ethics. We have to make sure we're doing the right thing for the right people, and we have to bring the public and build that trust in everything we're doing. And actually what we did during the COVID pandemic, even if it's busy as it was, we actually took the time to put in place an ethics framework to try and share with the public the reasons why we're doing the work we're doing, or why we're sharing the data in the way that we're sharing. And we want to really build on that and continue to open up more sources of data and more things. So to help us open up data, one of the big programs that I'm leading on right now, and one of our really big ambitions for digital health and care in Scotland, is our Digital Front Door programme. Now, I would acknowledge that other parts of the UK are further ahead in terms of opening systems up. We really want to make sure that we're opening up data in a very secure way, in a very safe way, but we're deliberately opening it up for health and care collectively. So we're not going to have an NHS app in Scotland, and the ambition is more to bring together health and care data in a way that will actually support the integration of those services. But actually, from a citizen, from an individual point of view, they don't really differentiate between health data or care data, or more importantly, other data that they want to share. So our Digital Front Door ambition is also about how do we bring you as individuals, how do we support you to share the information that you want to with the doctor, with the nurse, with the physiotherapy, with your care worker. And our ambition behind it all is to try and avoid this repetition of stories being told. Tell us your story once and we'll share it many times, and we'll share it in a way that works best for you. So we're aiming to launch this sometime over the course of this parliamentary year. And as I said, it's a really exciting development for us because of the way it's bringing together health and care services. It's also seeking to try and address the challenge that we have on digital inclusion. And Audit Scotland have actually been in recently and are planning to publish a report early next year. But we've also been very minded of around 10% of the population either can't engage with digital or choose not to. So it's very important for us in opening up services that we make sure we don't leave anyone behind. And we've done some great work with our Digital Lifelines programme in particular to try and encourage homeless population or those that are more likely to need addiction services to have better access to information, to support, to services, so that we can intervene earlier and hopefully avoid some of the very challenging situations that they're in. I also wanted to move on to talk about our delivery plan. So this is all great in terms of, oh, that sounds exciting, and yep, but when's it coming? So we've been very deliberate in Scottish Government to say we will commit to an annual delivery plan, well over 60 programmes within that plan that sets out very clearly what we're going to achieve, what we're working on, what the timelines are, and when we expect to see the benefits coming from that. So both that delivery plan and the data strategy I mentioned are published on the Scottish Government website. I'd really encourage you to have a look at that, as that's our kind of key document that we're using to engage with industry and to engage with other partners to say, here's the direction of travel we're taking. You know, can you help us? Can you come with us on that journey? So as I said, 60 commitments in there and across a very wide range of very, very different things, from a new patient identity system or CAI system right through to really supporting digital inclusion and digitally excluded people from accessing services. As I mentioned earlier, we can't do any of this without our workforce, and our workforce are critical to us in health and care. I would also acknowledge it's very difficult to recruit. And bringing people like cyber skills especially is proving very challenging at the moment. So what we're trying to set out is how we bring our teams together and how we maximise the people that are engaged in digital health and care in Scotland to work together, to collaborate with partners in industry and academia. We're also using technology, though, to support collaboration across health and care. And more recently, we've been working with all 32 local authorities, with the health boards, with Scottish Government, to use even very simple tools like Microsoft 365, but use that as a way of opening up who's available today, who can help me with this problem, who can help me with this challenge. I'm already seeing some very exciting work being taken there in terms of just bringing people together, and how we use technology to bring people together is really, really important to us going forward. From a workforce point of view, we've also just launched a new master's level programme. It's called Digital Transformation in Health and Care in Scotland. And really excited about that because it gives us that focal point and this opportunity to bring through the next generation of people who want to work in our industry. And we're delighted to confirm we've had our great first cohort on that, and really hoping that we can repeat that and move that programme forward. So it's really helping us take that next generation forward. And we've also been working at an executive level, at board level, to try and deepen the understanding of digital. So how can we support leaders in clinical areas or leaders in the care sector understand the opportunity that digital can bring? Because digital itself and data and AI and all these other exciting things are going to completely change the way that we work in health and care. And we need to be ready for that now. And just in terms of one last area to highlight, and again, really welcome the Q&A session that we have partners from industry and academia today, but absolutely wanted to recognise the important role that they all have in supporting what we are doing in Scotland for digital health and care. And we're sponsors of the DHI, the Digital Health and Care Innovation Centre, and key partners with them, but we also work closely with Data Lab to try and understand what technology is coming through and to try and work with new partners, new startups in a way that will really make a difference. So I also wanted to confirm in early 2024, we're going to be launching our next round of CivTech challenges. If you've not heard of CivTech before, that's the Scottish Government-led programme that tries to encourage startups and new ideas to come into areas of the public sector that don't have a solution. But we're actually uniquely going to have a CivTech challenge session focused entirely on health and care. And it's specifically going to be in an area that I think Tricia will touch on in a minute, around wellness. We want to innovate for well-being. And that's all about bringing health and care and other people together to say, how can we really change the lives of our citizens, of our people, so that they live better, healthier living lives. So really encourage you to look out for that early next year. We're just starting the process of understanding what challenges we want to address, but it will be around data, it will be around encouraging people to live better lives and how we can use digital and data as a way of helping that. So I just wanted to end on that and say, really welcome the discussion today. Really looking forward to your questions. As I say, really excited by the opportunities and the direction of travel that we're going in to make a big difference in digital health and care. Thank you very much.
Great, thank you. Thank you very much for a really good introduction to our discussion that really situates what we're going to be discussing in the context of policy and development in lots of sectors. So that's a really great start. Now I'd like to introduce Professor Patricia Connolly, who is Professor of Bioengineering at the University of Strathclyde and Director of Strathclyde Institute of Medical Devices and the Chief Executive Officer of Medics Limited, a spin-out of the University of Strathclyde. She is Deputy Associate or Principal for Research and Knowledge Exchange at the university, and she's co-leading the university's health tech cluster. So lots of relevant experience to bring us. Thank you very much for coming to talk to us today.
Thank you. So, wanted to cover a few things today to try and bring together some of the data interest and the technologies, to talk a little bit about where we think it's going to go, remembering there are commercial as well as academic interfaces as well as the NHS to think about. And where are some of the challenges here in this new monitoring, this new digital age, and maybe some, if there's time, some of the triple helix exemplars of what we can do on the academic side, working with industry and the NHS. So we have a lot of technologies already that we can monitor people with. A lot of stuff exists. There are gaps. But you can think of, I mean, everybody learned how to do COVID tests. It's fantastic how the population adapted to that. But, blood pressure, partial oxygen, your ECG, glucose weight, other lateral flow tests, maybe urine infection, etc., can all be done now. There are gaps that I'll come to. But in terms of, it's gone mad here, I went too heavily on that. In terms of, where we are, things can be picked out already. Small packages could be given to citizens and have been. We're already embarked on that. So we need to get this balance right by not reinventing the wheel or putting our effort where there is real need. And of course, the big tech companies are here. They are in this arena, they are global, and they are after health as part of their business. Now, they may stumble a few times. They've stumbled on devices a little bit. Apple's done, I think, a very good job on the Apple Watch about what it can do in terms of being a real health device. So they're going to get there, and they're going to have the trust of the consumers as well as they go. I had a quick look at, what can you get from Amazon right now on Amazon Web Services? And, there's all sorts of health offerings already here, and they're being used by NHS divisions as well. I like this Health Scribe one, your conversation with your consultant, how to get that written down. How often have you heard a relative want you to go with them if you've got medical experience to consultants, or you can't understand when they come back just what exactly they've been told? These are basic tools that really help people, but you can see everything that they're offering and more. And of course, Amazon's not the only one. And of course, there are commercial companies already in the zone. I just picked out 2 examples in healthcare, working with NHS. They have some contracts in Scotland, I believe, as well. Dokla, another company that we've been talking to, who have technology that can create what we would call virtual wards at home. Get people out of hospital, get them monitored in a safer environment, if you can. So where might this go? Some of the things we're starting to see and we're still talking about how to do. Home use self-management, there is real evidence from things like NHS Florence, a texting system, that if you give people the ability to self-manage and they buy in, they get much better results. So this could be wound management, urine infections. Sepsis from urine infections kills 65,000 people a year in the UK. Sepsis itself kills 250,000 in the UK. So early discharge to virtual wards, or maybe even non-hospitalised treatments, a paramedic on-site, stitches, checking, etc. And of course, in the hospital, faster diagnostics and digital could mean that you have your bloods done by the time you get to see your consultant, that you're not 2 or 3 visits, etc. And better prescribing could come out of some of these diagnostic tests, like which antibiotic to prescribe for a really bad urine infection. So there's a lot of gaps here that, because of the way we've siloed, of necessity, all our specialisms in NHS, people are passed from pillar to post for a long time. Maybe digital in the hospital will help that. So will we get better outcomes, less hospitalisation, really critically important, and reduced or removed chronic disease? There's a debate to be had in diabetes, because we know we can reverse most type 2 diabetes, but we don't really talk about it. So how are universities responding? Well, I think across Scotland there's great stuff going on, and many of you will be from these universities. At Strathclyde, we've founded a centre for the future hospital, hospitals without walls, and really trying to think into some of these problem areas. We'd like it, to cover all these. The least touch on this seems to send it off. To cover all these types of wishes to deliver. So we could, set up virtual wards. We'd be working with companies, virtual clinics, rehabilitation, post-surgery. What do you get? Just now, not very much. Post-stroke, etc. This could all be done in a more digital and personal sense in the home. But we're very interested in wellness, because if we don't get the population into wellness, the NHS will not cope. Chronic lifestyle diseases, lack of knowledge from teens and 20s and 30s, leading to people having chronic diseases in their 30s and 40s, which is, should be unheard of in a modern society like this. But how do we get people truly engaged in this? Because it's not just preaching to them, don't do this, or eat 5 a day, or whatever it is. It's the holistic approach. It's what motivates people. Eudaimonia, the science of, happiness. What makes you happy? Well, eudaimonia says a sense of purpose is one of the key things in it. And in some of our communities, how do we engender that? How do we give people the power to see their lives differently and change it, change their own wellness? Citizen engagement is critical, I think, to the survival of the health service over the next 20 years or so. And to really deliver new technologies, IT, AI, we need this so-called triple helix of collaboration: the universities, industry, and the NHS. We need the clinical need, we need the industries with the technology and the agility and the money to develop these things, and we need the universities. So we must mesh these systems together, and we hope that we're doing some of that. I'm going to give you some examples of sensors being developed where there is still a clinical need. So find the clinical need, for your technology. My spin-out company has got 3 platforms: one for wound detection, so for monitoring of wounds; one for bacteria. The next pandemic could quite likely be an antimicrobial resistance, so we need to get bacterial detection better. And of course, the futuristic, don't take any blood, have a wearable sensor, and we're working on that. In wound sense, we have a sensor that can go in a dressing. You don't need to take the dressing off, and a patient, a carer, or an attending clinician can measure the moisture and decide if the dressing needs changed. We reckon we could save up to half of the hospital dressing changes, and probably about the same in the community. Now, that's very disruptive. It's disruptive of nurse time, how they change dressings just now. It's even more disruptive for the wound care companies if we tell them, do you want to use our sensor, but you'll sell a whole load less dressings. So all of these new technologies are breaking into areas where there are already commercial and bureaucratic interests and ways of working, and humans don't really like to change that much. So there's a big business change thing for NHS coming up around all sorts of technologies. We have developed a home use or pharmacy use little sensor, little portable rechargeable instrument that you can put a urine sample into. You could, put a wound swab into. We've actually worked with NHS on this in NHS Ayrshire, looking at wounds. We've worked with Glasgow Royal Infirmary for urine, and within about 20 minutes you can get you're infected. You can tell that within 5 minutes inside this little reagentless cartridge. And a few minutes later, it will start to tell you if the bacteria has antimicrobial resistance to specific antibiotics. So technologies like this will make our prescribing better and our detection. Things like this in the home would actually hopefully avoid sepsis and some very serious events that can also occur in urine infections. And there's loads of the community, women, people with MS, who start to get a lot of problems with urine infections later. It's a bit of a hidden problem, I think, that people don't talk about much. And finally, on the wearable side, we're working with the DSTL MOD, testing a wearable hydration sensor, which at the moment is geared towards a more consumer use, a well-being use. And we've had quite a lot of interest from corporate well-being, how to get your staff more interested in their personal well-being. And if you can measure your hydration, and maybe you can monitor your food intake, etc. Is this a little tool that draws you into wellness? Back to that motivational thing. Could you share it with your friends online and say, oh, well, you were out last night, you dehydrated, I bet. We had an event at Lloyds Bank a couple of years ago with the first prototype, measured people, and they were queuing up, the younger folk, because they'd all been out the night before to see who was the most dehydrated. So that was fun. But this kind of idea of taking a wearable sensor, something that you don't have to prick your finger for, we can get through on this device. We can take glucose and lactate out of the skin. We can take small molecules. We've already had a short neonatal trial in the neonatal intensive care unit at the Royal Hospital for Children with 2 of the neonatal consultants there, to start to see if we could use it in a medical sense to stop taking blood from neonates, these babies obviously sick and premature in this unit as they transfer to health for a lot of them. Can we stop taking blood from them? So it has medical applications, but it also has, I think, quite a big consumer application. So I see the universities delivering things like this and the AI and working with the companies and having spin-out companies. I think the enmeshing, the adoption of technology is very difficult in the United Kingdom, sorry to say, and that hasn't changed much despite all the things. I've been back in the United Kingdom about 20 odd years, and people were talking about adoption of technology then and how it was all going to be better, and I hear the same statements, I'm sorry to say, even after today. But lots of people, in the groups there, medical diagnostics group at Strathclyde, Professor Roma Maguire for the Centre for Future Hospitals. So that there's lots of us there in the health tech cluster working together. And there's colleagues around Scotland, some of whom might be listening in, where we're building grant applications to do some of this multidisciplinary work. So I think there's a lot to play for here. And I think the challenges to NHS are how they handle that commercial interface and the different type of worker that will be required, because I think we're going to see a change in the types of health delivered and care delivered, and we can use this structure to deliver that. That's me. Go on to my next.
Well, thanks so much to Professor Connolly. That was a terrific introduction and a summary of a vast array of technologies that we can begin to think about. And as you say, they've got some big implications for where we're going to go next. So that's a really helpful contribution. Next, I'd like to introduce Professor Oliver Lemon. He's Professor of Artificial Intelligence and co-academic lead at the National Robotarian, and director of the Interaction Lab and a co-founder of Alana AI, which develops advanced conversational AI solutions in collaboration with agencies including the NHS and the Royal National Institute for Blind People. So please do come up and tell us more about your work. Thank you.
Okay, thanks very much for the kind introduction and the opportunity to speak. So yeah, I want to focus on all the really exciting things which I think a lot of people have partially heard about, at least, happening in AI, and particularly around things called large language models, and how we can think about embedding them into healthcare provision, how we can try to hopefully form partnerships that make it really beneficial for society. So I'm sure everybody has heard of ChatGPT, which happened not even a year ago, actually, and it's been absolutely remarkable and incredibly exciting what's happened in AI since then. And this is a kind of tree of how different large language models have developed recently. So yeah, ChatGPT happened about a year ago. This is often also called by several different names: generative AI, foundation models, and the latest thing people are talking about is large multimodal models. Multimodal just means combining visual systems and language systems, so that you can, for example, talk about images and generate descriptions of images and so on. So all the big companies are working now in this area. It's really exciting what's happening, and the challenge is to try and build these systems into useful healthcare systems and to embed them into real practice, I think. So I think we're all aware, we're always told that there's this coming wave. It is actually upon us. Large language models are here. They're very powerful. I'm going to try to just show a few examples of their power here. And they can be used to provide all kinds of tailored health information. They can be used to summarize complex documents, automate administrative tasks, analyze images, and so on. And actually, part of the problem here is they can be used in so many different ways that there's a real challenge to try and figure out what we should do first. And that's something that we need to work together, I believe, with healthcare professionals and practitioners to figure out the clinical needs, the real pain points to start with first. So I just want to illustrate a little bit, why are people excited? Why am I so excited about this advance that's been made? So I've been working in what was called dialogue systems, conversational AI for about 20 years. And over those past 20 years, we struggled to build this sort of holy grail, which was called the conversational natural language interface. And we spent a lot of time building very complex modular systems to understand human language and generate human language. And what large language models have done is to provide a really new, powerful way of building those systems, where the kind of science fiction imagination of what they could be has really pretty much reached a reality now. So we now have conversational natural language interfaces, and I'll show you why that's good in a minute. But they do actually do something more than that, which I think is really the other powerful thing to understand, is that they're actually instruction following systems. So in generative AI, you can interact in a conversational, natural way, but you can also give them instructions. For example, write an email to my doctor explaining the following things, and it will generate you a very nice email in 0.2 of a second. But many, many other things can be done in terms of following instructions. So just as an example of why conversation is powerful, this is something we do in a project, it's a European project called Rescue. Rescue is focused on providing conversational AI for people who've had a stroke. And the idea is that we have a conversation with that person, partly to find out how their recovery is going. So we will ask them certain questions, about their condition, and then we'll use that as a way of sensing their condition. But also we want to just provide support to them so they can better understand their condition. So we've developed an application on mobile phones. You can either speak to it or type to it. And you can ask these kind of conversational questions. How many types of aphasia are there? 'Cause maybe someone's had a stroke and they now have some kind of aphasia, but they can't remember what the consultant said. And the answers that we deliver are actually grounded in trusted document collections. So the very important thing here is that the AI generates this answer, but it does it based on specific collection of documents which you effectively tell it are the trusted source of truth. So that's one way around dealing with problems of hallucination of large language models. It's not a totally solved problem yet. But then we can also look at very sort of quite complex questions like this. What are the differences between Broca and Wernicke's aphasia? Even though there's a typo here, the system is able to deal with it. But this is a complex question involving decomposition into, I need to know what these two different types of aphasia are, and then I need to compare these things. So the AI system is actually able to do the kind of reasoning, multi-step reasoning involved in finding the documents, comparing the documents, and then generating this type of answer here. So that's just a little example of the power of a conversational interaction. And then what I also mentioned was instruction following. So this paper came out overnight, actually. I got this in my inbox this morning. This is the latest version of GPT-4, which the V stands for visual. And this is an example of automatically generating a radiology report from an X-ray image. So the prompt, this is the instruction you give to the model. The prompt is write a radiology report for this image as an expert radiologist. The system scans that image, automatically generates this report. And in this paper, which I said was published yesterday, I think, they have medical professionals checking these generated reports, for example. And there are sometimes errors, which they can correct, but sometimes these reports are absolutely, very, very high quality. And there are many more examples in the paper of how you can build generative AI now which works directly on images and is able to rapidly automate these kind of processes, which would take really a long time for a medical professional to produce, but can still obviously be checked by humans. And I think that's another key aspect of what we need to figure out here is how we, this is now possible. How do we fold that into existing workflows so that people can use it in a way that actually sort of amplifies and supports their professional practice and makes it easier for them to do their job, even more fun for them to do their job, frankly. I think an important thing we need to think about is that AI needs to be fun to use, fun for people to adopt. And I believe this kind of interactive conversational aspect is at least one element of making it fun enough for people to actually want to use in their jobs and their everyday lives. So I think, we hear a lot about the promise and the peril of these generative AI systems. It's well known that they can hallucinate, they can generate text which looks beautiful and very convincing and is in fact contains some errors. So it could be persuasive and believable, but actually wrong. We and a lot of other people are working on lots of methods to try to address that problem. There's also known issues of bias where the models are trained on data which is discriminatory in different ways. And again, of course, you can imagine lots of people are now working on trying to restrict the training data sets for such models. A very important aspect that the general public is rightly concerned about is privacy and security issues. So I work in a couple of projects where we actually put AI in hospitals, and the key issue there is that no data is allowed to leave the premises. So we have actually had to build rather small generative AI systems which can be run on hospital premises without data going to OpenAI, no data goes to Google, these kind of things. And of course, we need lots of data for model training, and that's something we need more partnerships on and to obviously work hard to make sure that the public is reassured that all the data we use is fully anonymized. Something we've mentioned already is the issue of job displacement. There's a lot of discussion politically, quite rightly so, about how this coming wave is going to alter the workplace. So we need to work hard to figure out how we can augment people's existing jobs with AI. And that's what I said about, AI should be fun, right? We need to make it so that people want to use it because it makes them faster, it supports them, and it can help them to do other things in their job which are more useful and productive. So that means working on this kind of, I think, a co-pilot kind of metaphor where you have your buddy, your AI buddy, who's helping you to do all the tasks you need to do. And that's how I personally use things like GPT-4 and so on. But we need to build these kind of partnerships between people who work in AI, who are developing these systems, and the medical practitioners who are actually doing the job on the ground. Okay, so we have a spin-out company. So just to declare an interest, I'm a co-founder of this company. And as I mentioned, we're involved, just as an example, in building AI for people who've had a stroke. So this is a European project about stroke care. And as I mentioned, we are building these kind of conversational question answering systems to help people understand what's happening with them and also tracking their progress in recovery. We also have some partnerships with NHS in England to work together to build these kinds of AI co-pilots, and particularly focusing on visual question answering on images. So we're starting to build these connections between academia and industry and NHS and so on. And it feels to me like really early days, and there's a huge amount to do, but it's starting to happen. So I should mention also the UK's National Robotarium. So this is This building now exists. It's out at Heriot-Watt University near the airport. And it's just had its first birthday. And I work there quite a lot. And we're obviously focused on all types of robotics applications. But actually, I put this picture up as kind of a warning. We're not we're not really obsessed as the media is with this kind of humanoid robot, although we do work with humanoid robots and they have their place, but we're really working on solving the core AI problems that make robotics possible. So in order to do good robotics, you need very good computer vision, you need very good planning, you need, if you want to interact with them, you need some kind of language understanding, and so on. And so we work really on the core AI that makes robots possible. So just, you should think of it as a kind of embodied AI, and we're working exactly on building those kind of large language model systems into robots, and we've had a lot of exciting progress in the past year, which I'm personally really happy about. So what we've done recently is put together large language models with these embodied robots. So this one is an animated 3D face where we actually generate the facial expressions along with the speech, and we use it as a receptionist for the building. But also we've built a similar system into this robot called an ARI robot, ARI. And it is actually deployed right now in Paris in a hospital, a memory clinic in the Broca Hospital in Paris. So it's a project called Spring. And what it does, and I think it's, we're evaluating whether it's really useful, is it captures a lot of patients' everyday questions, which the medical professionals in the building get quite annoyed by having to answer these repeated questions, and they told us that they felt it was quite a waste of their time to keep having to help people, directing them to where the coffee machine is and where the lift is and where the bathroom is and which bus to get back home and all these kind of things. So we've built this system. It actually speaks French, and that's another thing which is amazing about these large language models. They're actually multilingual. So we were actually it was very easy for us to translate the system from English to French. But it's in the hospital waiting room, and it helps people to find out where to go next, where to get lunch. All these kind of trivial but important questions have been sort of automated away. And I'm really excited by the quality of the system. It's just so much better than what we could do a year ago. Okay, so I'm just going to wrap up. Obviously, there's a huge opportunity here, not only in humanoid robotics and human-robot interaction, but even in the things which may appear to be more mundane and boring, but automating a lot of administrative tasks, automatically generating patient notes or updates of patient records, all these kind of things which can really improve efficiency. So this new wave is actually here, and there are many, many opportunities, but we need to be very aware of the pitfalls and work very hard. In particular, the most serious one is obviously the hallucination problem, particularly in healthcare settings. If you get the facts actually wrong about an image that you're looking at, this will have serious critical consequences. So we and many other people are working really hard on trying to solve the hallucination problem. So we need to work in a way that these risks are balanced, and I believe one of the main things there is to always keep a human in the loop. So you have an AI co-pilot or an AI as part of a team of humans, and ultimately it needs to be the humans who make the final decision. And a question I have, which I hope maybe we'll come to in the panel, is how can we actually work together across academia, industry, and NHS and government and so on to really collaborate properly to realize the opportunities that are here. So for me, just a personal perspective, a key thing is data partnerships. It's really important to have high quality data and lots of it to build these models really well. And just as a plea, as with my academic hat on, that's really hard to get hold of. But another thing is the co-design of these systems. So we have to start, and we already are starting, talking with healthcare professionals to figure out how such systems can be really made useful to them, and to make their jobs better, more interesting, and as I keep saying, even more fun to do because they have AI beside them. Okay, that was everything I wanted to say.
Fantastic timing, well done. Thank you. Well, thank you very much, Professor Lemon, for bringing all sorts of additional thoughts to mind. How to make this fun? I'm intrigued. And also, obviously, it's a recurrent theme in these presentations, and it's obviously very important to think about some of the risks and how we're going to help people to adapt to using this kind of methodology. It's beginning to be a really big conversation we're having. I'd like to introduce next then our final speaker, Dr. Ken Sutherland. Dr. Sutherland is a leading engineering figure at the interface between medicine, engineering and the life sciences in Scotland and the UK generally. He's president of Canon Medical Research Europe and is currently directing a new initiative in artificial intelligence and data by the recently funded Industrial Centre for Artificial Intelligence Research, I'll say it again, Artificial Intelligence Research in Digital Diagnostics, the ICARD. So please do come up and tell us more about the things you're doing.
Thank you very much, Sarah, and thank you very much. Thank you. Please save it for the end in case I'm not any good. But yeah, thank you very much for the organisers for the chance to speak here, and thank you very much to my colleagues and friends for their earlier presentations and for stealing some of my thunder. It's always difficult to speak last because people have normally spoken about what you want to say, but actually it also gives me a chance to contradict and to correct some of the previous speakers as well. So I shall take that opportunity, obviously. But no, being seriously. I want to talk very much about what Oliver's just talked about, which is the challenge of getting data, and the challenge of getting data in volume for us to be able to start to do exactly what we need to do, which is to train models in a safe, secure, appropriate way that respects all of our data and respects the fact and understands the fact that if we do it badly, we create biased solutions that won't work and will actually increase health inequality when we're trying to do the opposite. First of all, very briefly, I want to tell you that I do work for a big company, but we don't consider ourselves to be a big tech company. We're not a nasty big tech company because we're Asian. We're Canon. We're Canon Medical, which is a division of Canon, the company you may well be aware of because we make printer scanners, photocopiers, document imaging solutions, cameras, all that sort of stuff. Japanese company, but we're here in Scotland. We're here in Scotland with a company that was actually an acquisition, but it was formed almost 30 years ago now. It'll be 30 years in January that the company was founded by three guys who came out of the University of Edinburgh back here in 1994. We're now about 140 people, still based here in Edinburgh, and I'm responsible for that organisation. We work with universities day to day, and we work very closely with NHS and Scottish Government colleagues like Jonathan and his other colleagues. So just a tiny sec about what we do. So we really come from this world of imaging. Oliver's already shown you a picture of this. This is some of our most modern 3D visualizations that you get to see. But it's not good enough, actually, just to produce beautiful, pretty pictures like this. We've got to help, now we've got to help, as Oliver's just explained, we've got to help the available humans in the system to work as efficiently as possible and try and automate some of the tasks that are drudgery and try and allow people to move forward as rapidly as possible, because the demographic challenge is unsolvable without more technology. There are just too many of us living too long in need of healthcare and not enough doctors and care staff to look after us. Very simple problem, difficult to solve though. And part of the solution is clearly AI. And I'm very proud of the fact, and we should all be proud of the fact, in this room at least, that Canon, as an international company, Japanese-owned multinational healthcare business, decided to put its AI Centre of Excellence here in Edinburgh. And it didn't just do that because I persuaded them and I'm a really nice guy to work with and all that, and I've got really smart folk working for me. Wasn't that. It's because of the history and the opportunities here in Scotland. To work with the universities you've just heard speaking earlier on today, and to work with the NHS and Scottish Government and the support we've got from all across the system here in Scotland. So Scotland really is a great place to do this work, and it's recognised by a major multinational, the decision to go and do this here. So we're very lucky, actually. The timing worked really well as well. When we started this about 6 or 7 years ago, more recently than that, about 5 years ago now, some money became available from Innovate UK as part of the industrial strategy. And this was under, I don't know how many prime ministers ago, Theresa May, that there was industrial strategy and a life sciences sector deal. And it talked very much about AI, and it agreed to fund a number of different centres looking at AI within healthcare. And one of them was in Scotland, and that's the iCared Industrial Centre. I will struggle to say it as well. Industrial Centre for, it's not even here. Where does it say it? Industrial Centre for AI Research and Digital Diagnostics, which had a group of different organisations supported by Scottish Government, the CSO, Chief Scientist Officer here in Scotland, another multinational, not just ourselves, but Philips were also part of this and supported by another NVIDIA, who make the fantastic compute platforms that people use to do AI nowadays. And we created truly an embodiment of this triple helix model of innovation that Trish spoke about when she spoke as well. So it's absolutely that. Very difficult to put together a big consortium, though. I just mentioned this in passing. Probably a couple of years in the formation to get from the original idea to a funded project that actually kicked off at the scale of which it is. And the scale is big, so it's about, or originally the scale was about £15 million, with about 10 million coming to Scotland from Innovate UK, because they recognised our ability to create a consortium here in Scotland and to do the work that we were able to do with the support and the stakeholders we've got here in Scotland, which is great. So what happened? Well, we started off with relatively, so there's two parts of the project. One part was the bit that we're involved in as a company in radiology imaging, which is the pictures I showed you earlier on. The other part was the pathology side, which is really looking at slides. So histology slides, microscope slides, and whole slide scanning and stuff like that. So in the radiology side, we started off with a relatively modest project, 3 different exemplars, working across Glasgow as a site and Grampian and Aberdeen as a site, supported by the relevant NHS bodies and universities to get going. What we actually delivered during the project ran an extra year because of COVID, actually ended up running for 4 years instead of 3. We delivered much more. We created a COVID work package, we created some other work packages as well, and absolutely built a much bigger and much more comprehensive programme of work that is essentially still continuing, although I will say more about that in a moment. On the pathology side, we started off with even smaller ambitions, working fundamentally with Glasgow and Philips, but again, in fact, even more impressively, managed to build a fantastic network of projects. Why were we successful? Okay, very simple. So the model is different from the previous model of AI training in healthcare, the one that's broken and gone wrong. So instead of us as a company going to NHS and saying, give us your data, we'll take it, we'll put it in our data centre, we'll put it in our in-house computers, and we'll do our training, we did the opposite of that. We said, no, you keep the data in your safe and secure environment, we will come to you. We will come to you virtually, or we'll come to you physically, we'll log into your systems securely and all that sort of stuff, and we will do our AI training within your safe haven, within your infrastructure. That model is transformational. Number of reasons why it really works. First of all, it respects the ownership and privacy and all that sort of stuff that is incredibly important for all of us as citizens, because it is our data. It's nobody else's data. It is actually our data. So it respects that, firstly. Secondly, if you do it there, you're actually not taking cleansed, exported data. You're taking the real data as it is. What does that mean? Well, that means that when you create your algorithm that uses that data, it was trained on real data, therefore it will work much better on real data. If you create a completely sanitized view of the world and you train your AI in that sanitized world, it will fail in the real world because the real world is dirty and not sanitized. So that's one of the other advantages of this model. So we changed the model, and therefore we were able to get other people recognize what we were doing was different and came to Scotland. UK companies, other outside Scotland, came to Scotland to work in this way. Multinationals like ourselves and Philips came here to do this because we're able to do it here in Scotland. Just a quick summary of the core achievements. So as Canon, we got involved in inventing the Safe Haven AI training platform, SHAPE as we call it, which is really a way in which we enable that idea that we come to the data. Pathology Lab was able to digitize a whole pile of slide scanning equipment and create a digital archive now that's available for research and ongoing use. And we created a number of different ways in which we were able to create a true partnership. And the numbers are quite astounding when you look at it. So we started off with about 15 Started off with about 15 partners and 15 million. We ended up with 40 partners and 25 million and about 250 staff working across the project. And we're able to access 75 million medical images. So when it comes to training, data and volume of data is the most important thing you need to be able to do. So I think one of the offshoots was another project that was created. This was again part of the project. We just came up with the idea. This was actually done in Aberdeen under the Opportunity Northeast programme, again with support from Scottish Government. There was an SBRI scheme, the Small Business Research Initiative way of funding a project. And about 100 companies came to Scotland for the teaser session to understand what was happening because we'd created a pool, we created a reason for someone to come here and do this here, which is really about the availability of data and the willingness and the triple helix model of collaboration that was available for all of these people and innovators to come here. They say that imitation is the most sincere form of flattery. NHS England last year decided to launch a scheme of what they call the Secure Data Environment Initiatives. They backed that with almost 200 million. Now, in truth, the actual money is less than the 200 million, as ever with government announcements. And I'll say something about Scotland in a moment, and Jonathan knows I'm going to say it, and he'll hit me for it later, but I'm going to say it nonetheless. So actually, it's more like 100 and something million. But what they're doing is exactly the model we piloted here in Scotland with iCare. They're creating regional centres where you go to the data, where the innovator, whether they're a business or an academic or just an independent person, they go to the data. They use a piece of technology called federated learning to allow you to connect these individual pools of data together so that you're learning something in a truly generic way and not just creating a piece of AI that's trained in Aberdeen and will only ever work in Aberdeen because the population of Aberdeen is completely specific. Apologies from anybody from Aberdeen. I could have picked anywhere for that. And I don't think it's necessarily true that everybody from Aberdeen is identical, but I say it nonetheless, that unless you create, and this is a key thing about bias within AI training, if you want your AI to work for a global population, you have to train it on a representative global population or it won't work. Just won't work. There are well-documented examples. And this idea that you go to the data, it's not realistic to have international pools of data that people can go to on a scale. What it is realistic, though, is a company or an innovator could go, do some training here in the UK with the NHS, go to the US, go to China, go to Russia, go wherever you might be able to want to go to create a representative population for the world. That's what you need to be able to do. England's doing it. We've committed to doing something in Scotland earlier, and this, as I say, Jonathan will hit me for this later. This was a commitment from Scottish Government in the programme for government for 21-22. A bunch of other things happened. This hasn't happened. But as you've already heard from Jonathan, there's a whole pile of work going on today within the NHS to make this data available, to make the platform, the level of digitisation much higher. So I hope that we can get to what was originally envisaged with this commitment in a slightly different way. So I'm optimistic with that, and I'm still working on Jonathan to make sure that happens. So help me with the Q&A later on with that, if you don't mind. That's me. Thank you very much for your time. I hope that's been useful. Thank you.
take a seat here if you'd like to. Thank you so much. That's another very thought-provoking set of ideas. The idea that you can do this development locally, and I'm very impressed by the way that the Scotland is leading and providing an ideal location for this kind of research. So many thanks then to all our speakers. We're going to move now towards the Q&A session. And I'm going to see if I can log into questions which are coming from the floor. Again, if you prefer not to use the online system, we have some of our colleagues here who are going to be there with microphones, which I think they're cleaning as they take them round, so they're very, very, very hygienic microphones, I gather, to give you an opportunity to ask questions that way. I'm going to start by taking a question that's come up online. Seems to be a very popular question amongst several of the others who are taking part. Incidentally, if you see a question that you think is a really good question, please do give it a tick so that we can see that there's plenty of support for it, and we'll try to prioritise those which lots of people want to know the answer to. So the question then is, are we using the data to understand the country's needs, especially in the mental health sector? So would anybody like to come back on that one? And I invite any of our speakers to put their ideas forward. Jonathan, have you got a thought you'd like to begin with?
It's actually was an area I considered actually mentioning as part of my opening remarks. Mental health is a really exciting area actually for us, and we're seeing a tremendous growth in particularly citizen-held support. And I think there's more to be done, but I am already very encouraged by the direction of travel we're taking, with the way that many people have actually embraced the use of apps and technology in that space. I'd maybe highlight one called Sleepio, that's been supported by Scottish Government in terms of really supporting mental health and people being able to sleep well and recognising the benefits from that. So there's always more we could do with data, but I think the emphasis we're placing on mental health is really to make sure that it works for the individual. And then the longer term benefits will be from those data streams that we get will be then, right, how do we shape that for the greater good of the population? So colleagues in Public Health Scotland are often pulling on these types of data sets to help then shape or influence or advise us as policymakers in Scottish Government to say, this is the direction of travel, this is what we're seeing from the data. And from my perspective, it's very important that that's done independently. I have to stress that, you know, every time you hear a statistic about the NHS in the news, it is independently verified and controlled through Public Health Scotland, who are independent of government, and so that helps build that trust in the data as well. But I don't know if colleagues want to add to that point.
Can I just check if everybody here okay at the back of the room? Is that coming over clearly? Yes, if you could speak quite loudly and clearly, please. We might need to boost the microphones a bit that you're using.
Sure.
But a number of good points. Yes, thank you.
Yes, just to come on that. The general point is, I think here, that actually what we want to do, it's difficult, but what we want to try and do is aggregate different data sets about individual patients in a safe way that they can still be interrelated. So many of you will be familiar with the term of precision medicine, and precision medicine, simplistically, so I'm an engineer by trade, I'm not a medic, so apologies in advance if I say something that is, is this actually working? Okay. So precision medicine is a term that refers to using essentially all the available data you've got about an individual patient and then treating them as an individual and coming up with a personalised care plan or intervention plan for them based on their characteristics. So, for example, Jonathan and I could have the same disease, but the treatment that works for me might not work for him and vice versa. And it might be because of our genetics, it might be because of our environmental exposure, it might be our lifestyles, might be any number of different things. And the only way you can solve that is you have all of that data coming together. And I think that when we talk about mental health, we talk about any other challenge like that. What is necessary for us to start to use data effectively is to start to aggregate all of that data. And it's not just the healthcare data, it's the social care data, as Jonathan mentioned, but it's also socioeconomic grouping, maybe even your postcode is a determinant of your health and your outcome. So we need to bring all of that data together when we're doing this training. The model I've talked about, this idea of these sort of safe havens for data or trusted research environments, secure data environments for another term, they allow you to do exactly that. So yes, the answer is yes, people are working on this. Not our business as Canon Medical, but other companies are already working on this as well. Yeah, just to add.
Unless anybody else on the panel particularly wanted to come back on that one, we do have a number of other questions. Was there a question at the back of the room that somebody wanted to ask, or was it just a wave about the volume? Good. Is that better for you to hear now? Hopefully everybody can hear us. Do signal if it's not clear, and we'll try to make sure that you can hear at the back. The next question I've got, how do we upskill our health and social care workforce in digital skills and use of data and technology? Challenging to meet training requirements already. So I think we've heard a little bit about this in the talks already, but can you give us some more ideas about that? Would anybody like to come back on that one? I'm looking at you actually, see if, Oliver, to see if you might want to comment on that.
Well, I think one way to start is to weave these applications into the kinds of systems that people are already using. So that's why we, for example, try to put things on mobile phones, for instance. And I think for some kind of applications of AI, that's going to be relatively easy to fit it into people's sort of everyday experiences of the kinds of systems they already use. But in other, and again, I'm not a healthcare professional, which is why I really want to start working together with professionals on this. And again, in other types of situations, there's just no two ways about it. You will have to train people specifically to use these new methods. But I think part of the power of the conversational AI setup is that pretty much everybody knows how to have a conversation and how to get things done using words and language. So there's an element whereby you hope that conversational language is a kind of universal interface where you can effectively have one mode of interaction with AIs, which you would repeat over many different types of use cases. So again, that's a little bit utopian, I think, because when it gets down to the details, that's not going to be precisely true. But hopefully, that's part of the solution to this.
Good. Want to add to that?
Yeah. I think one of the things that we didn't talk about was regulatory, and this is a well-regulated field when you're in medical diagnostics, and it's going to come for AI as well. There are already many things underway for that. If we look at a medical device and how training is done for clinical or assistive staff, that training would be done by a company or in cascade training, train the trainer. And again, I go back to the fact that I think the implementations of many of these systems will be out of our academic hands. We'll do the development, they will go out into the companies, and we will be working with companies to get training packages together and to meet the medical legislation where you have to ensure that users are trained to use devices or technology. So I'm hopeful that we'll see something coming together at that commercial NHS interface, which will stop NHS having to worry too much about that. But I can see the need for CPD and upskilling and other things to get people interested in the area, and new pathways perhaps for some types of healthcare assistance or clinical staff.
Thank you. Did you want to add anything to that?
I'll just add one very brief point. I suspect we're having difficulties with the volume at the back, and I know there's a lot of questions in the room as well, but it's not just about skills. The key word I've been using is actually confidence. I think staff can be trained, they can be skilled. It's giving them the confidence, particularly when it comes to analysing data or to explaining that to a patient they're treating or to someone that they're working with. So often it's actually about permission or having the confidence to say, yes, that is right. So workforce development is also just about giving people the assurance and the confidence that they're doing the right thing. And that's sometimes equally as important.
Thank you. Maybe we're going to be following on a little bit from those last comments. I've got a question which was directed particularly to Patricia, but maybe others will have something to say as well. The question then is, Patricia, you emphasise that the adoption of innovations in the UK is challenging. What barriers are specific to the UK that you see as needing to be addressed?
I think one of the key barriers is fragmentation. We talk about an NHS, but really we have a very large conglomeration of different companies, if you look at it from a business perspective, and each of them has their own culture, and each of them wants to have their own pilot for a new device. They want their own data. So UK government has failed, I think, and Scottish, to roll out actually devices or technologies. We have NICE, who are quite capable of telling you the advantages of a technology, but it doesn't come with any implementation law for it. So there's that aspect of it. I think also in terms of NHS, people to champion new technologies and new ways of doing things. I think we've found, certainly as a company, and others may be able to comment on this, that it's very difficult for even a small team who are interested in a new product to get it through the whole hospital or system. And I think that this idea of lines of command when it comes to new technologies, devices and products, again, is something that really should be looked at a higher level in NHS and in government, because these savings need to be made. But at the moment, people can simply choose not to adopt because it doesn't suit their routine. There was a time just after the whole system demonstrator when in NHS England, there was innovation penalties for boards, and if they couldn't show that they tried some innovations, I think up to 3% of their allocation of funding was withheld against that. I'm not saying that's necessarily what to do, but I think it's very open now. If you want the technology, you can maybe take it. If it's only one small team, you're not going to get it in. So I think that's, and maybe Ken would echo that from a bigger company perspective.
Yes, just briefly to add to that. So working internationally, it's interesting. We do see things from an external and an internal perspective. I think there is a challenge here, and I don't know the answer to this. There's a challenge here in the UK because it's very difficult for us to pull people away from frontline NHS service. And if you're going to improve what you're going to do, if you're going to change your workflow, and we haven't really talked about this that much, I think, Jonathan, you mentioned it, but new innovation almost always requires a workflow change, which means a habit and a pattern has to be broken and then replaced with a new pattern or habit that works in a new way. That's intensive of people's time, energy, brain power, and it requires people to step away from the frontline action, learn the new thing, engage with it, and then implement it again into the active line of work and the active workflow. We just struggle to find the capacity to do that here in this country. We all know the background to that. It's mentioned it earlier on, this demographic challenge, too many patients, not enough doctors, not enough care staff. Somehow or other, that's very much, in my view, part of the problem here, is that getting people away. And it's very difficult, because do you want that? If you're waiting for a dermatology appointment, do you want the dermatologist off trying to work out how to do dermatology better, or do you want them seeing your loved one or yourself? Tricky.
And we have got a question at the back. Maybe we could move to... there's a microphone coming, I think.
Thanks very much. Really interesting and relevant talks from everyone. Thank you. A few of you mentioned about the challenges of accessing data, representative data, so we don't build bias into everything we train. And that resonated so much with me as a clinician, a frontline clinician who knows that we have done such a bad job of building silos. And actually, Ken almost set me up here. As a frontline clinician, I think we are never going to solve the problem unless we move away from doing what we love, treating patients, which I've done, and trying to change how we make better use of our patients' data and not wasting it. And I had kind of two questions around that. One is very close to the field in which I work, which is dealing with non-anonymizable data, photos of children's faces, videos of them talking. When we train as doctors, when we teach our junior doctors, we say, don't look at the numbers, don't look at the x-rays, first look at the patient. And we are training the most powerful tool in medicine to help us co-pilot and do medicine better, to do everything but look at the patient's face. So I think we need to have a very real-world conversation with all the stakeholders about it. We need to do it right, but we shouldn't ignore the one thing that tells us the most about patients. So I'd love folks' thoughts on that. We've got the ability, we've trained algorithms to look at x-rays, histopath slides. There are so many things we are potentially missing because we don't look at faces. I mean, other thing about data, there's another type of data that we're using to train large language models. And as I say to my patients, the internet has some really fantastic information and some really dodgy information. So how do we constrain what these large language models learn from? How do we also mark for the future internet content that is regurgitated from a large language model that then becomes this circular self-fulfilling prophecy?
Thank you very much. Any thoughts? Yes.
So taking the first part and using data that's inherently recognizable or potentially recognizable. So as time has gone on, we've moved from the more supervised training models for AI into unsupervised models of training. Supervised models of training means that probably an expert has to sit down and draw around the tumor or draw around the lung or the heart or whatever it is you're trying to train the AI to recognize. But we've now got to a stage, partly because of advances in technologies like large language models and natural language processing, is in some cases we can use the report and the image to train the model without a human being involved. Now, again, it's maybe a little bit philosophical point, but if the model is seeing the inherently recognizable data rather than a human, then is that such a problem? As long as we're confident that the model isn't remembering that explicitly. And that's a key thing about the model. The model doesn't remember everything it's seen. It remembers a generic, generalized version of everything it's seen. So as long as we're confident of that, and we can now check that, there are AI techniques that can check that the model isn't just accumulating everything it's seen and then be able to regurgitate it. So that would be my answer, is that if we move to truly unsupervised or more unsupervised learning, then we can reduce the risks. Unfortunately, there always will be a risk. I think it is important that, I would agree with you, the AI needs to see the person if that's what we're expecting the AI to do. Although, again, we're maybe getting ahead of ourselves, because I actually agree with Oliver's point about there being a human in the loop today, being the endpoint decision maker. And I see that, in my mind, for the foreseeable future. Although it's a rapidly moving world, maybe the foreseeable future isn't that far in advance, because I didn't predict ChatGPT a year ago. So, yeah, we'll need to wait and see. But
I think the public actually are very supportive of even their non-anonymizable data
Yeah.
being studied.
Yeah.
And if I may, a slight spanner in the works about supervised versus unsupervised learning from a clinical perspective. Sometimes my medical
Yeah.
colleagues, my world, can be a little bit arrogant that the classifications, the gradings, the signs they look for are the best way to analyze things. So we can easily train algorithms to replicate how we score things, but I think my world has to be open to the fact that some degree of unsupervised learning
Yep. And it's sadly not consistent, because one of the things we have learned from supervised learning is that we can ask three different radiologists to do the same task and produce a different answer, unfortunately, all of which can be correct, but they are different.
I guess that also in our minds there's issues that certainly as someone using administrative statistics, I'm very conscious of the need for a great deal of care about risking any possibility of disclosure and protecting anonymity, which perhaps we haven't quite emphasised enough today, I feel, because while some of the solutions you're suggesting certainly do seem to be very helpful.
Just picking up on that just for a second, sorry to interrupt you,
Yeah,
just for a
please
second. The model, as I mentioned, the model we did with iCare and the model within the English NHS England SDEs is that the data doesn't leave that secure environment, which is where it is today anyway. So as long as we're confident that that's secure, then us being able to access it, as long as the method of access is also secure, then we shouldn't have increased the risk, is the intent at least. But I would agree with the comment from the previous questioner about, in my experience, general public are very willing, as long as there's trust. Yes. And we've got to work, I've got to work, all of us have to work on that trust to make sure that there's transparency about how your data has been used. It's not been used to sell you insurance or to calculate a risk for insurance or stuff like that, unless that's what we say we're going to do with it. But
okay, so
we're not. No, sorry. Just to be clear, neither Jonathan or I are doing that.
You've mentioned trusts, and lots of hands have flown up. So shall we take one or two questions from in the room here? I'm not quite sure who came up first, but perhaps it's a similar question. What was your question, please?
Hi. I was really taken by what you said, that you can only put in, you need to put in global data to be able to get the right results back. I mean, I think it's about a few years ago, they said that 1 in 10 people in hospital were due to side effects of drugs. And we know that clinical trials are not very good at representing everybody, especially women and kids. Do you think that AI is there a space for AI in the clinical development of drugs and the safety of drugs? And do you think the fact that we've shown that we need all of this data, global representation to have, correct imaging, will actually put pressure on how we do clinical trials?
Absolutely. I would definitely, to your second point, yes, I would absolutely hope so. I mean, rightly clearly wrongly, but kind of rightly from a selfish point of view, I am over-researched. I'm a white European man, and I'm over-researched in terms of over-represented in all medical research for, since the beginning of we started doing medical research. That's clearly incorrect. And I think this absolute requirement to produce equitable and unbiased AI will drive a change in behaviour patterns. To your first point, does AI have a role in that sort of drug discovery that actually would help to balance the way that things are done at the moment? Absolutely, that is also true. There are very large companies now existing, trading entirely on the use of AI to come up with candidate molecules and stuff like that. This is a very active area, yes. So yes, but it all still needs care. And it all still needs the transparency to make sure that people are acting in the way that we imagine them to be acting, or we would hope them to be acting. And it does need that transparency and regulatory checks and balances to secure that.
Any other comments on that one?
Yeah, I just wanted to add, yes, as Ken said, a very active area, and in fact discussed it with the Chief Pharmaceutical Officer in Scottish Government recently, is just the potential that this area opens up. And you're absolutely right, 1 in 10 people not taking medication correctly is probably higher than that. But it's also why we're trying to put some of the data in the hands of people. And we're really, trying to open up ways of the citizen themselves being able to take their medication more safely. And there's lots of low-tech innovation that would make a difference. There's just disclosure boxes. There's, very simple apps and checks that can be made around, taking a photo of the medication, or, so lots of other ideas. But for me, at the heart of it has to be the person themselves and understanding why they're taking the medication, so that they then do the right thing with that. And yeah, the more pressure we can take off A&E from these very simple steps while we wait for the really exciting world that's coming around AI, and it is coming, and it's definitely an area that's really exciting.
Thank you. Was there, yes, another question at the back there?
Yeah, hi. I work I'm a clinical fellow at the Digital Health Validation Lab, so working quite closely with ICAD, and we've got Canon offices in our building as well. And it was interesting to hear about the emphasis on good data coming in, because I'm fortunate enough to be involved in a lot of projects that are using sort of human in the loop AI training algorithms, and then I go to my clinical shift literally 200 meters away, and all of the data is still being captured on paper and is blinded. So it's sort of like go from the Charlie and the Chocolate Factory situation, where there's all this really exciting innovation that seems to be very dependent on individual consultants, individual teams just saying, we're going to do this. So like the cardiologists have a really good data set that they're publishing a lot of data out of, and we're going to train LLMs on that. And then there's other specialties that, and in fact, the vast majority of hospitals I've worked in Scotland / the UK are still on paper notes. No one's going to get access to that data from 2023 before. That's going to be blinded to any LLMs.
I would absolutely agree that digital maturity is a challenge, although, Jonathan, this is more you than me.
Yeah, no, it is. I mean, digital maturity actually is a process we've just undertaken, not just with the health boards, but actually with local authorities and a number of other partners to try and understand challenges like that. It's that analogy of you can lead a horse to water. You can put the tools there, you can try and demonstrate the benefit, but sustaining that change is and I think coming back to the barriers and innovation, it's also the barriers to just using digital technology. It comes back again to the confidence point. So we've actually been doing a lot of work in prisons recently, where again they're very reliant on paper, but actually some of that challenge is around their infrastructure. There's not Wi-Fi access in many parts of a prison, therefore it's actually easier to use paper. And some of the behaviour is actually influenced by just some very basic infrastructure not being in place. So a big part of what my team are doing are actually, can we really just check we've got the core basics right before we start getting all, the exciting things in place. So even just the basics of broadband connectivity going into at the right level, at the right size. So we've just signed a new deal with BT for the Swan contract, and straight away we're getting new connections in, faster connections in, looking at 5G, the work that the 5G Centre have been doing. How does that help transform access to digital that then will stop the reliance on paper? So it's a complex picture in there, but some of it's behaviour, some of it's not having access to the right infrastructure, and some of it is just being as well. It's a comfort, and they know what they're doing, and I think coming back to the point Ken made, under pressure as well, the workforce will fall back to what feels like the right thing to do.
Thank you. I'm going to stretch our time limit slightly to just fit in two more questions. There's one here in the front of the room.
Sheila Bird, a medical statistician. And so Jonathan mentioned you tell your story once and just once only. But one of the first things I did as a research assistant in medical statistics at Edinburgh University was an observer variation study, 4 consultants seeing 12 patients with stroke in the course of an afternoon, designed order. And for one of those patients, they were confined to bed with one consultant, and another consultant had them walking up and down the ward. So the observer variation is extremely important. And so even although AI might applaud itself for using dirty data, I think there should be experimentation with, for example, 10% of people having the history retaken by another, and some formal experimentation within AI to find out how much better you would do if you did have checkability. So randomized controlled trials are data by design. They are not get it anywhere and grab it. randomized controlled trials don't tell us about pharmacovigilance, and I do think that AI has a lot to offer in terms of pharmacovigilance because we do it rather badly. And the data are very dirty, but I think you've got a lot to offer us. But I think there should be more attention to design and some experiments within the AI setting.
Thank you. So, randomized control trials. Potentially quite a controversial question because they're very good from many points of view, but not from every point of view. Does anybody want to comment on that?
I think I absolutely agree, and that's part of the scientific work we do around developing AI systems. Is we test different variants of them, different ways, for example, of trying to get a patient's information. Yes, you're absolutely right that it's the design and optimization of these systems is requiring that kind of traditional scientific work with actually experimenting with, different modes of asking people questions and so on. And we need to be always introducing variation into these kind of systems. It shouldn't always be doing things in exactly the same way all the time. Also because we need to adapt and personalize to different people. There's a lot of personal variation in, your propensity to answer questions depending on how they're asked. So, absolutely agree. And there's lots of fascinating work to be done and partially being done on those kinds of issues. Yeah.
Thank you. A very brief additional point.
Just a very brief point. I think one of the things is true, and I take the point well made. We're absolutely still learning what AI should be able to do and shouldn't be able to do. But some things are amazing. A generic model for image recognition trained on essentially pictures of cats and dogs on the internet is incredibly good at recognizing anatomical structures in radiology imaging with a tiny amount of additive data specific to radiology added to the vast data of cats and dogs and stuff like that on the internet. So it's amazing. We don't really understand it, but I completely agree with you. We need to understand it if we're going to use it in a safe and appropriate way.
Thank you. Well, I think we probably have got to the end of our time now, so I'm sorry that we can't take any more questions. There are lots more online as well, so you've really got us all thinking hard. I hope that some of the questions that were put earlier on have actually been directly or indirectly addressed. And sorry we can't take all the new questions from the room. But I think it now falls to me to, first of all, thank all our speakers. They've really got us thinking, haven't they? And I'm certainly going to go home cogitating a little bit on what you've all been raising. I'm sure that's the truth for many of us as well. I'd like to thank all the attendees, everybody in the room. Fantastic to have you here. Very good to have your comments and questions, and great to be able to meet with you all. And we're really pleased to have even more people attending online. We've had, I think, around 200 people participating one way or another in this event. So it just goes to show how important the issue is, and how we need really to extend this conversation, I think, and perhaps keep thinking about the kind of the way that we work on it. I'd also like to thank the staff here at the RSE for all their help in getting this set up and helping us with all the technology and so on. And thanks to the Foundation of Science Technology for supporting this activity and working with us on this. So I think now it's time to invite you all to move up to the welcome rooms for the networking and drinks reception for those of you that are here. And for those of you online, we wish you a very good day, and thank you so much for taking part. We hope to be able to keep in touch with you all, and we hope that some networking may be being made online as well as in the room here. So now I think it's time to close the event. Thank you.